Hello, everyone. Welcome to the 15th Grand Round of Asia Pediatric Pulmonology Society, or APPS. My name is Rina Triasih, and it is my pleasure to join you today as the president of APPS. In this occasion, I would like to wish all our Muslim colleagues a blessed Eid Mubarak. May the spirit of Ramadan continue to inspire us to grow and to serve with compassion and dedication. Over the years, APPS has grown and we are proud to offer several scientific platforms. In addition to our bi-monthly Grand Round, we also publish our official journal, the Pediatric Respirology and Critical Care Medicine. I encourage you to visit the journal website and to submit your works in our journal. We also host an annual scientific conference. This year is the 11th, and it will be held in Hong Kong from 30 October to the 1st of November. Abstract submission is now open, and we warmly invite you to submit your abstract, to share your research, and to join the meeting. Today's Grand Round is kindly hosted by the Korean Academy of Pediatric Allergy and Respiratory Diseases. I would like to express my sincere appreciation to Professor Kang Mo-an, the president of CAPART, and to the entire Korean team. My thanks also go to all speakers and moderators for their valuable contributions. Special thanks for Dr. Ngo for her continued support and coordination on the Grand Round since its beginning. It is now my pleasure to introduce today's moderator, Professor Chang Keun Kim. Professor Kim is a professor at the Department of Pediatrics and the Asthma and Allergy Center at Inje University, Sangye Park Hospital, Seoul, Korea. He was the 28th president of the Korean Academy of Pediatric Allergy and Respiratory Diseases. He conducted research focusing on eosinophil and asthma biomarkers during his total 5-year fellowship period at Mayo Clinic, University of Wisconsin, and National Jewish Health in the USA. With that, I hand over the session to Professor Kim. Thank you for joining us, and I wish you a productive and interesting session. Thank you.
Good evening, everybody. My name is Kang Mo-an. I'm working in Samsung Medical Center, and I'm the president of the Korean Academy of Pediatric Allergy and Respiratory Disease. I found this photo on the app's homepage. According to the record, the first app's scientific congress was held in Hong Kong in 2015, 11 years ago. I'm very happy to join the 15th Grand Round of apps. Before I begin, I'd like to thank all participants for joining this Grand Round this evening. I would also like to acknowledge the Korean colleagues who will give case presentation and discussions, and express my sincere gratitude to Dr. Ngo from Singapore for her invaluable assistance. Today, it is my great pleasure to briefly introduce Korean Academy and share our vision for future collaboration with apps. Okay. And this is the homepage of Korean Academy of Pediatric Allergy and Respiratory Disease. CAPART was established in 1987 and has grown into one of the leading academic society in pediatric allergy and respiratory disease in Asia. We actively organize a biannual congress and biannual study group symposia and biannual CME courses. Through these activities, we aim to advance both the clinical practice and research capacity in our field. COPART also contribute to global academic advancement through our journals. We have two journals. The one is Allergy, Asthma, and Immunology Research, is which is our official English language journal with an impact factor of 4.3. We also publish Allergy, Asthma, and Respiratory Disease, our official Korean language journal, which supports regional academic communication. COPART has several well-organized study groups covering major areas such as asthma, rhinitis, food allergy, atopic dermatitis, respiratory disease, sleep disorder, and healthcare informatics. These groups play a key role in conducting multi-center research and generating clinical evidence in our society. Among them, the PRED, the Pneumonia and Respiratory Disease Study Group, focuses on pneumonia and respiratory diseases. It conducts research on community-acquired pneumonia and pathogen surveillance, mycoplasma pneumonia, bronchiectasis, chronic lung diseases, pediatric chronic cough, and pediatric rare lung diseases such as cystic fibrosis and primary ciliary dyskinesia. This group has produced meaningful multi-center data that directly impact the clinical practice. Based on these collaborative efforts, COPART has generated numerous high-quality publications and guidelines and clinical guidelines. These include national multi-center studies and evidence-based recommendations, contributing to both scientific knowledge and improved patient care. We believe that collaboration is essential for advancing pediatric respiratory medicine. We have established a partnership with European Respiratory Society and American Thoracic Society, and through a dual membership program, an increasing number of our members participate in their annual conferences and contribute to scientific exchange. Looking ahead, we are preparing the 2027 COPART APAPARI Congress. This Congress will be held from April 21st to April 23rd in 2027 at the Lotte Hotel World in Jamsil, Seoul. We will provide a unique and engaging environment for both academic and social experiences. We sincerely hope that APS members also will join us at this important meeting, which will provide a valuable platform for deeper collaboration in our region. The Congress will include 5 plenary sessions and approximately 20 to 25 symposia. Our scientific program committee is considering organizing one symposium session in collaboration with APS, including the joint selection of the topic and speakers. We will also celebrate the 40th anniversary of COPART and the 30th anniversary of APAPARI. Through a strong scientific program and active international participation, we aim to further strengthen regional cooperation. COPART is committed to advancing pediatric allergy and respiratory diseases through research, education, and global collaboration. We truly value our partnership with APS and look forward to further strengthening our collaboration in the future. Thank you very much for your attention.
Thank you very much, Professor Rina Triash. As Professor Kang Mo-an and President Rina said, we are very happy to have experts from different countries today and share our knowledge. So before we start the session, I would like to introduce our excellent participants, including 3 panelists and a presenter. So The first is Professor Kangmo An. As he presented, he's currently the president of CAPARD and the Department of Pediatrics, Samsung Medical Center, Sungkyungan University, Seoul, Korea. Professor An, just give us a short, brief hello, brief greeting message.
Yeah, hello, night, good evening. I already did, so you can just pass.
Okay, thank you very much. The next is presenter Professor Jisoo Park. Jisoo Park is um, he belongs to Division of Pulmonology and Allergy, Department of Pediatrics and Adolescent Medicine, Seoul National University Hospital, Seoul, Korea. Jisoo, just to say hello to everyone.
Hello. Nice to meet you.
Okay, okay, that's it. Next is Professor Basil El Najir. He's a consultant and pediatric respirologist and cystic fibrosis center from and Children's Health Ireland. Professor Basil Lar.
Good afternoon from Dublin, Ireland. Delighted to be in APS again. Thank you.
Thank you. And Professor Majid Arsal Altanoji. He's a pediatric pulmonologist and sleep physician, Al Jalila Children's Hospital, Dubai, United Arab Emirates. Professor Altanoji.
It's always great to be part of APPS. Thank you for the invitation. Be exciting.
Okay, lastly, Professor Dong-in Seo. He's from Department of Pediatrics, Seoul National University Hospital, Seoul, Korea. Dong-in, please.
Hello, I'm Dong-in Seo. I'm really honored to take part in this symposium. Thank you.
Okay, now let's start the program. And Jisoo, please start. Please begin the presentation.
Hello, thank you for the introduction. I'm Jisoo Park. I'm an assistant professor in the Department of Pediatrics at Seoul National University Children's Hospital. It's a great honor to be here today and speak in front of you and present our case. So our case today is an apneic full-term infant in the NICU. First, the present illness. The chief complaint was persistent respiratory failure and ventilator dependence since birth. A 2-month-old female patient was transferred to our ICU. She was born at gestational age 37 weeks, 2.3 kilograms as F1 of DCDA twin via C-section due to breech presentation. Her antenatal history was unremarkable. She had good fetal movement and no maternal medication was noted. Her initial APGAR scores were 10 and 10 at both 1 and 5 minutes. But soon after, she developed desaturation and apnea, which required intubation and surfactant administration. Meconium was passed within 24 hours, but she had 3 failed attempts of ventilator weaning due to apnea, so tracheostomy was performed at 1 month. Even after tracheostomy, she experienced sudden respiratory arrest, likely secondary to airway spasm, and CPR was performed for 40 minutes before retrieving RSC. So endoscopic evaluation revealed tracheomalacia, and an adjustable lung cannula was placed to maintain the airway patency. And then she was transferred to our ICU. Review of system revealed no abnormalities except for the respiratory domain because she was on she had tracheostomy and was on mechanical ventilator support, but she didn't show any signs of infection or other systemic illnesses. On physical exam, her vital signs were unremarkable. She did show mild fever of 38 degrees Celsius, but other than that, her saturation was 97% with ventilator settings, and she had no other signs of other illnesses except for she had expiratory stridor on auscultation. On neurologic evaluation, she didn't show any neck stiffness. Her consciousness was good, and cranial nerve examination was all intact. Her motor function was also all good. She did not show any pathological reflexes. Moving on to laboratory findings. When she was on PSV mode on the ventilator, she shows CO2 retention of PCO2 99.7. But when she was switched to SIMV mode, that was alleviated. But whenever we tried to wean her off the ventilator, she showed CO2 retention. Her CBC and chemistry labs were all unremarkable. On the X-ray, except for a mild gaseous dissension on the abdomen, her lung field didn't show any abnormalities. Furthermore, on EEG, there was the record was normal EEG. On echocardiography, except for a small secondary ASD, she didn't show any other abnormalities. So to wrap up until now, the problem list is as follows. She was born at term. She was well at birth with APGAR score of 10 and 10, but she developed apnea and she had repeated ventilator weaning failure, and she showed hypercapnia, especially on the PSV mode. She showed no neurological deficits and normal echocardiography except for the small ASD, and she had normal EEG. Which brings us to the first question. What is the most likely diagnosis? 1, spinal muscular atrophy type 1, Rett syndrome, Prader-Willi syndrome, congenital central hypoventilation syndrome, or Duchenne muscular dystrophy. Okay, the polls are coming up. Do I close the poll or? We have about 44% of people coming in. The numbers aren't going up anymore.
That's great. Thank you very much, Jisoo, for that. I think my job is easy now because this is a very well-informed audience. And if I can advance my slides, please, assist. Yeah, okay, thank you. So basically, just to wrap up what Jisoo has just told us, this is a term infant, very good fetal movement with no antenatal concerns, good APGARs at birth, but definitely desaturated and became apneic, requiring resuscitation. Another word of interest here is that the child or this baby passed meconium in the first 24 hours and ran into trouble requiring intubation and subsequently securing airway via tracheostomy transferred to the other facility. So that brings us to the definition or the main title of the presentation, which is apnea. So the origin of word apnea comes from the ancient Greek apnoia, and apnoia with the prefix of an A or alpha means without or not, and the pnoia is breathing. So basically apnea literally means without breathing or cessation of breathing. So what is apnea? What's the definition of apnea? The textbook definition of apnea is a cessation of respiratory efforts lasting 20 seconds or longer. Or if not 20 seconds, then if it is less than 20 seconds, it should be accompanied by other symptoms such as bradycardia, pallor, or cyanosis. We all know that it's very common in premature babies, particularly due to immaturity of the brainstem respiratory control centers. But as we know here from the presentation, that we're dealing with a full-term baby. There are different types of apneas. Simply, we can summarize them into three major categories: central, obstructive, and mixed. And I'm sure we all know that the central is where we have no efferent output as a result of a depressed respiratory center, and hence the inspiratory efforts are completely cessation. There are obstructive apnea symptoms, and this is you having good inspiratory effort, however, not effective in ventilating the child due to obstruction to the airflow. And then the mixed apnea, both central and obstructed. We will talk about this a little bit more in details. But I think it's pertinent at this stage to try and figure out, put in a generic picture at what are the causes of apnea. And there are different causes of apneas. We spoke initially, the commonest is the premature babies, but we're dealing with the term baby. So what are the causes of apnea in term infants? Infections head the list: neonatal sepsis, meningitis. Pertussis is very important and usually carry a high risk of mortality in the neonatal period. Neurological causes such as seizures, neurological abnormality, structural abnormality, hemorrhages, hypoxic ischemic encephalopathy. Other metabolic causes or inborn error of metabolism, hypoglycemias, dyselectrolytemia would cause apnea in a term infant. Respiratory, such as airway obstruction, congenital airway abnormalities, and aspiration. I just need to remind you, in this child, the chest X-ray looked normal with no evidence of parenchymal changes. Cardiac, certainly dysrhythmias can lead to apnea or other congenital heart disease. This child had a normal cardiac evaluation. Other causes are congenital conditions, and this is usually related to problems like congenital central hypoventilation syndrome, later on in bigger children, Prader-Willi syndrome. And physicist, can we move the slide, please? It stopped moving for me. I think the slide, yeah, next. Yeah, that's, yeah. And in children, in older children, respiratory causes such as adenotonsillar hypertrophy, and that results primarily into obstructive sleep apnea. Other conditions such as severe life-threatening asthma, bronchiolitis, pneumonias, and foreign body aspiration. Neurological condition in children such as seizures, increased intracranial pressure, or brain tumors. And again, like infants, cardiac dysrhythmias or congenital heart disease can result in apnea in children. Metabolic conditions, dyselectrolytemia, and inborn error of metabolism. Behavioral or functional, some children might have breath-holding episodes, usually self-limiting, known to be sometimes associated with iron deficiency anemias. And we should not forget evidence of toxic intake of medication or otherwise, resulting in central depression and apnea in children. Genetics, we spoke about the congenital central hypoventilation syndrome, or late onset hypoventilation, or ROHAD, rapid onset obesity with hypothalamic hypoventilation and autonomic dysfunction. So by and large, this is the catalog for causes of apnea. What about hypoventilation then? if it is related, if we start at the top from the brain down to the spinal cord, down to the neurology and neuromuscular junction, these are the different causes with congenital central hypoventilation syndrome, late onset central hypoventilation syndrome, ROHAD, tumors, Arnold-Chiari malformations, and so on and so forth. Things related to the pump includes the spinal muscular atrophy, spinal cord injury, Guillain-Barré syndrome, phrenic nerve injury, and myasthenia gravis, albeit non-common in this age group. Muscles, muscular dystrophy, myopathy, and that's why in the poll we had Duchenne muscular dystrophy and spinal muscular atrophy. What about pulmonary conditions that results into hypoventilation? Things like pulmonary hypoplasia, aspiration, pneumonias can result into hypoventilation. Congenital thoracic malformation can result into hypoventilation. Chronic lung disease, airway abnormalities such as laryngomalacia or obstructive sleep apnea. Systemic conditions such as metabolic alkalosis, sepsis, obesity, or CNS infection can result into hypoventilation. CNS depressant drugs or inborn error of metabolism or other conditions, as we mentioned earlier, such as Prader-Willi, would result into hypoventilation. So these are two long lists of apnea and hypoventilation. So what about apnea in term infants? A recent publication in the Archives of Disease in Childhood looking at nearly 100 infants born at term, averaging about 2 months, and nearly under 50% of these children were reported to have apneic episodes secondary to gastroesophageal reflux disease. 37% have upper airway abnormalities, and 19% neurological disease, together with 5% including seizures. So this is a general poll in cause of apnea in term infants. How can we quantify this? And Dr. Tineji and my colleagues would speak to this later. Now, usually we have a thermistor nasal flow to try and identify if there's any flow, with EEG to have a sleep architecture, and 2 respi bands or chest and abdominal inductance plethysmography to give us a feel of the movement of the chest and the abdomen, with transcutaneous CO2 and pulse oximetry. So this is a cartoon to depict the obstructive apnea we spoke about, the binomial flow. Suddenly there's a cessation of any efferent output, resulting into a paradoxical movement of the rib cage versus the abdomen. So whilst we are at the nadir of the rib cage movement, we are at the peak of the abdomen, so like a seesaw movement. Whereas if we look at the central apnea, complete cessation of the efferent outflow is translated in no movement in the rib cage or the abdomen. So how would we work up this child? Polysomnography, as I alluded to earlier in the previous picture, is the most accurate and comprehensive way to assess these children. Brain imaging to try and identify if there's any brain abnormality. Cardiac evaluation, as has been done, looking into any element of dysrhythmia or any structural cardiac problems. Neuromuscular evaluation through a comprehensive neurological examination with EEGs to try and decipher if there was any abnormal brain discharge, and the tone of the child, electromyography, and nerve conduction study if needed. We screen these children for inborn error of metabolism for evidence of dyselectrolytemia or metabolic conditions. An important point that was alluded to, that the child did open her bowels in the first 24 hours. So we look for any evidence of gastrointestinal dysmotility, and obviously molecular diagnostic tests, which will be touched upon by my colleague, Dr. Tineji, later on. So the key observation for me in the presentation is the timing of the apneic episode. It was immediate at birth, or was it late? What about the state of, or the stimulability and the state dependence? Was it worse when the child is asleep? Did the child react or respond to the state of hypoxia or hypercapnia? Are there any associated signs to record? Seizures, The tone of the child was floppy or otherwise, any autonomic instability in terms of temperature control or heart rate variability. In this presentation, the baby was term, was well at birth, had apneas. Another interesting feature is that despite multiple attempts to wean this child had respiratory failure, so meaning that the child failed repeated episodes of ventilator weaning. An important concept was the child was put on a pressure support ventilation mode, but that did not help the hypercapnia. And I think Professor Dong will touch on this later on. There was no neurological deficit. There was normal echo and normal EEG. Differential diagnosis to help me reach a diagnosis in this case is that this child was term. There was no CNS pathology, although unfortunately the child did arrest and required a prolonged resuscitation until they get ROSC back. But we know that there were no any evidence of congenital brain malformation. A metabolic screen did not show any abnormalities, and the child did have genetics testing, which will be touched upon in that one. The red flag pointing to the possible diagnosis of congenital central hypoventilation syndrome is the severe hypoventilation with hypoventilatory response blunting to hypoxia. And that's usually what happens in these children during sleep. Another red flag is the prolonged ventilatory support despite no lung disease identified. There was abnormal heart rate variability. There was no evidence of any Hirschsprung or constipation or GI dysmotility feature. And as well, there was no family history of sudden unexplained infant death or known FOX2B mutation in this child. I'll leave you with this final slide, and I'm sure Dr. Tineji will allude to this later on, but I want to touch on these two important things here. Despite the high PCO2 and the very low PO2 or oxygen saturation, there was no increased flow or increase in the tidal volume in this child with very low heart rate variability. Heart rate variability would be an important feature to justify sympathetic dominance. And it is known in children with or during hypoxia that there is low heart rate variability, particularly in children with congenital central hypoventilation syndrome. So with that, I'll pass you on to my colleague, Professor Tineji, or maybe pass you back to Jisoo again for a quick update.
Okay. Thank you, Basil. Okay, so moving on. So we know that we have to suspect CCHS. So after admission to our hospital, we did the FOX2B sequencing to confirm CCHS, and she had a polyalanine repeat mutation with a heterozygous genotype of 2027. She underwent another EEG so that we could rule out seizures. She said she had no EEG changes during the apnea events, and the record was normal for her age. On day 7 of the hospital days, she was put on a home ventilator. We had a safety tidal volume of 30 milliliters, so that she has guaranteed volume put in. And her long TCAN was maintained because she still had posterior tracheomalacia. Continuing on, she was moved to the general ward from the ICU. We performed a 24-hour Holter exam to look for any cardiac arrhythmias. In this study, she showed overall sinus rhythms. And on day 17, when we did another endoscopic exam, we found that her tracheomalacia was improved, so she was switched to a conventional T cannula. On day 29, we performed a colon study to rule out Hirschsprung's disease. There was no evidence of transition zone, so ruling out Hirschsprung's disease, but she still had some slightly prominent dilation of the S colon. On day 31, she was discharged with a home ventilator and tracheostomy. And moving on to the second poll question, which of the following specialties should be involved in the long-term management of this patient? Pulmonology, because we're pulmonologists, or cardiology, or neurology, endocrinology, hemato-oncology, or all of the above?
Oh, look.
Majid, your mic is off.
Okay, excellent. So we have almost everyone mentions all of the above. So let's see. All right. So for this talk, so what we'll focus on in the next few minutes is the pathophysiology of CCHS. So particularly looking at the FOX2B mutation. So as we've seen that the lungs of the patient is structurally normal, but the patient has hypoventilation. And when we talk about CCHS, we want to know that this is quite rare. So the estimated prevalence is between 1 in 100,000 and 1 in 500,000. And we have about 3,000 individuals identified worldwide with CCHS. So CCHS, as we know, is caused by mutation of the FOX2B mutation, which is the paired-like homeobox2B mutation. And this mutation was discovered in 2003, so it's quite recent compared to many. And it's located on chromosome 4. So I like to think about 4 FOX, so this is a way to remember it's on chromosome 4. And it's inherited in an autosomal dominant fashion, with 90% being de novo mutations. Of those mutations, what we see is that 90% of those are heterozygous, as Jisoo mentioned, and these are known as polyadenine repeat mutations. So when we talk about the mutations, we need to understand that in a normal state, on the chromosome, on exon 3, there are normal genotype of 20 alanine on both copies. So for them to code normally, they will produce that normal protein when there are 20 alanine repeats. But if patients had the FOX2B abnormality, those have polyadenine repeat mutations, end up having between 24 to 33 alanine repeats sequences. So that will be described as 20 to 24 up to 20, 33. So our patient has 20 to 27. Now, what we know is that the longer expansions are generally associated with more severe ventilatory dysfunction. On the other hand, we have an interesting one, which is the non-polyadenine repeat mutations, which has nothing to do with polyadenine repeats. So these are a result of a frame shift or a missense or a nonsense mutation. So they don't produce the normal protein and end up with a dysfunction. And it's very important for us to, one, identify the gene and then identify the type of the genetic mutation, because the genotype correlates with the phenotype, and that has its own clinical implications. So what we tend to see in the data is that the severity and complications do vary. So patients with polyadenine repeat mutations tend to have less severe clinical picture, so less likely to have continuous ventilatory support as they grow, less likely to have Hirschsprung and neural crest tumors, when compared to patients with non-polyadenine repeat mutations, which have the more severe form. Now, what we want to know from a clinical point is that FOX2B is expressed in the brainstem respiratory nuclei, in the autonomic ganglia, so that's our autonomic nervous system, and in the enteric nervous system. So what that does, it regulates the development of the chemoreceptors that control our breathing, the respiratory control in the brainstem, and the autonomic ganglia in different parts of the body, which we'll allude to in the next few slides. And finally, in the enteric nervous system. So all in all, what we think about CCHS as a developmental disorder of the autonomic circuits. So the question is, how does this mutation affect breathing? So we'll have to probably zoom in and go to our respiratory center at the brainstem, particularly looking at the medulla. And this takes us to the critical structure, which is the retrotrapezoid nucleus, RTN, which acts as a carbon dioxide sensor. This, when it functions normally, because it expresses the FOX2B, it will signal the pre-Potzinger complex, which generates the respiratory rhythm. So there's a normal response to carbon dioxide. However, when there's a FOX2B mutation, it disrupts the function of that RTN development, and the brain loses its ability to appropriately rising CO2. Now, when we look at the normal child, if they have an increase in carbon dioxide, their brain is going to sense that because of the normal carbon dioxide sensors, and in turn, that response will cause an increase in ventilation to maintain normal capnia. On the other hand, what we have is patients with central congenital hypoventilation syndrome, because of their failure of autonomic control we just explained, results in a reduced ventilatory response to rising carbon dioxide, and hence ending with hypoventilation. Interestingly enough, those patients do not really have a lot of response when their oxygen saturation drops. And more interestingly, like Dr. Basil did mention, is that they're worse during sleep. However, in comparison to most of hypoventilation syndromes, they're worse in non-REM sleep compared to the others, which are usually worse in REM sleep. So that's a classical thing that you have to look at. Then those patients do have the absent perception of dyspnea despite having hypercapnia. So this explains why those patients may appear remarkably comfortable despite severe hypercapnia, which is something that you have to take into consideration when they present with a respiratory illness, because they can fool you, and you have to really get a blood gas and make sure that their oxygen saturation is normal. Now, when we talk about CCHS, there's the neonatal onset CCHS, which we probably see the most of, and that's the commonest. Those patients do present immediately after birth, and usually within the first days of life. The manifestation may be respiratory arrest or progressive respiratory failure, sudden onset of cyanosis either during sleep or feeding, or evidence of a low tidal volume on central apneas when they're being monitored in the ICU. So those patients fail to increase ventilation or arouse despite having hypoxemia and hypercapnia, and usually will require mechanical ventilation early in life. On the other hand, we have the late onset CCHS. So the late onset CCHS is less common and is often more subtle. And the reason is that with those patients, we have the shorter polyalanine repeats, so make it less likely to be obvious initially. So they will present usually after infancy. And though we say it is late onset, it's not showing up later, but rather that it's there, but they will need something that's going to start that cascade. So that could be an acute illness, going under general anesthesia, or maybe incidentally when they are sent in for a sleep study. In some instances, they may present with an unexplained hypoxemia, hypercapnia, pulmonary hypertension because of chronic hypoxemia and hypercapnia, or cardiac arrest. So what can happen with most of those patients? Most of these patients do require ventilatory support lifelong during sleep, while some may eventually require it still while awake. So we would expect that children with age, they will need to sleep less, and they will likely need ventilation only during sleep. So the ventilation is important to know of that it may worsen during general anesthesia or sedation, during an acute illness, or during events of sleepiness or inactivity. So these are events that need to be taken into consideration when the child is ill, to be more vigilant and be more proactive in management, and in some instances may need different ventilation strategies or backup ventilatory modes. The other thing is we want to think about, because FOXP2B mutation regulates the autonomic neural crest development, it affects multiple systems. So this includes the cardiovascular system. We'll think about them having maybe bradycardia or sinus pauses, and that's why ECG is important. The blood pressure dysregulation was just highlighted by one of the members. Ophthalmologically, we think about pupillary abnormalities, maybe an abnormal pupillary light response, and that's a good way to screen those patients during the workup for hypoventilation. They'll develop a bit abnormal, so they'll have some developmental delays down the road, obvious maybe when they're older. From a gastrointestinal perspective, you'll think of them having maybe some dysmotility, gastroesophageal reflux, constipation, and in some cases, Hirschsprung disease. And most importantly out of all is the neoplasms. So because of this being a neural crest development abnormality, you think about neural crest origin tumors, so neuroblastomas or ganglioneuroblastomas. And this is a very nice image that can depict most of the conditions that may occur with children with CCHS. Now, circling back to this genotype and phenotype, knowing about the genotype can aid us in surveillance. But generally, for most of the patients with CCHS, we'll want to do multiple investigations at the time of diagnosis. That will include a formal polysomnography, echocardiogram, a complete blood count, a blood gas analysis, electrocardiography with 72-hour continuous monitoring, and neurocognitive testing. These are done every 6 months from 0 to 3 years, and then annually from 3 years and older. Now it becomes much more detailed when it comes to neural crest tumors. So as we said, the non-polyadenine repeat mutations are the most severe and the more likely to have neural crest tumors. Will be more vigilant in doing a chest and abdominal imaging, urine catecholamines for neuroblastoma. So for the first 0 to 2 years, we'll do this every 3 months. So ignore the typos, it says every 6 months, so it's for every 3 months. Then beyond 2 years, until 7 years, we'll do it every 6 months. Now, for the polyadenine repeat mutations, the one at up to 228 and longer, we will have to do the chest imaging and abdominal imaging annually. And anything less than 20 to 27, such as the one in our patient, is not really required because the likelihood of a neural crest tumor is much less. So the take-home message of this section is that it illustrates how the genetic control of the autonomic development affects the respiratory physiology and affects multiple systems as a whole. And then knowing the genotype and phenotype can guide us in terms of the clinical management and surveillance. Jisoo, this is yours. Thank you.
Thank you, Majid, for the beautiful review. Okay, continuing on with our patient. So during in our outpatient clinic, she was followed up by various departments. First, in pulmonology, we did regular follow-ups with ventilator setting adjustments. The recommendation is to do PSG every 6 months, but in reality, it's very, very hard to get a spot in the PSG sleep lab. So we don't do PSGs regularly, but we only look at the CO2 levels and the saturation monitoring and adjust the ventilator settings. So her home ventilator application was 24 hours a day at discharge. But at 20 months of age, she was using the ventilator only during sleep and during eating. And currently, she's only on nighttime ventilation 10 hours a day. In terms of her tracheostomy, she's on speech cap training when she's off the ventilator since 27 months of age. In the cardiology department, she showed bradycardia with desaturation without desaturation on EKG once. So after that, we were doing regular follow-ups in her Holter exam. In year 2023, she had a max RR interval of 3.25 seconds, which is a pause longer than 3 seconds. So we were considering doing a pacemaker insertion for her. But then on the next Holter exam, this improved. So we are still keeping a close eye, but not, she has not inserted a pacemaker yet. In the neurology department, she's doing a little bit worse. She has several ER visits due to seizures and seizures with desaturation. And because she had increasing seizures, she's on multiple seizure medications right now, and she is still being followed up because of her seizures. In the endocrinology department, she had one episode of syncope due to hypoglycemia. So we are monitoring her blood sugar levels. In the rehabilitation medicine department, they are doing regular follow-up with developmental assessments, which I will talk about in the next slide. In the ophthalmology department, they're doing regular checkups, but she hasn't shown any abnormalities in her eyes. So these are the developmental assessments that was done. On her Bailey scale evaluation at 24 months, she showed delay only in her language domains. At 30 months, she's still showing delay in her language domain, and she's starting to show some delay in the cognitive domain. At 36 months, she shows delays in the cognitive and language domains. At 4 years, we did a more thorough test. In terms of her adaptive and social functioning, she shows low social quotient, and she shows delays. And in terms of autism, she showed mild to moderate range of autism-related behaviors. And she had a very delayed developmental profile of lower than 10 to 12 months when she was actually 4.5 years. Next, we have our next question. So the patient has reached 6 years of age now, and the parents inquire about the long-term management of ventilatory support, specifically whether weaning from the mechanical ventilator or decannulation may be possible. Which of the following best reflects your opinion? Number 1, the patient will require lifelong invasive ventilation via tracheostomy. She may transition from invasive to non-invasive. Or 3, alternative ventilatory support modalities may allow weaning from ventilatory support. Number 4 is pharmacological therapy will allow complete weaning, or we can do RNA-based therapies. Okay. This question shows some divided answers. Answer is divided into 1, 2, and 3. And I will pass it over to Dr. Dong-in Seo.
I cannot take the control. What can I say? Okay. Hello, I'm Dong-in Seo from South Korea. Today I'm talking about the new and emerging treatment options for ventilatory support in CCHS. As a follow-up to the previous speaker's poll, my answer would be the patient may transition from invasive ventilation via tracheostomy to non-invasive mask ventilation. The other options are less appropriate because lifelong invasive ventilation is not always necessary. Complete weaning from ventilator support is very rare. Pharmacologic therapy is not yet effective, and gene-based therapies are still in preclinical stage. I will go through the rationales in the following slides. So this brings us to a key question. Is weaning from ventilatory support actually possible in CCHS? In most cases, the answer is no. CCHS is a lifelong disorder of central respiratory control, and true spontaneous resolution is extremely rare. However, this does not mean that nothing changes over time. What we often see is that ventilator support requirements may decrease, particularly as the child grows. And in selected patients, it may be possible to transition from continuous ventilation to nighttime only support. So rather than asking, can we completely wean? A more appropriate question is, can we safely reduce the level of support? And this shift in perspective is important for long-term management. So if complete weaning is rarely possible, the next question becomes, what are our available options for managing ventilation in CCHS? Broadly, these can be divided into two groups. First, currently available ventilator support modalities, including tracheostomy ventilation, non-invasive ventilation, diaphragmatic pacing, and negative pressure ventilation. And second, emerging therapeutic approaches such as pharmacologic therapies and gene-based strategies. At present, ventilatory support remains the cornerstone of treatment. However, as you can see, the field is gradually expanding beyond conventional approaches. In the next few slides, I will go through these options in more detail. So let's look more closely at the four main types of ventilatory support. In clinical practice, the choice of modality is not fixed, but depends on multiple factors, including the patient's age, severity of disease, duration of ventilatory dependence, and importantly, family preference and lifestyle. Now, briefly going through each option. Tracheostomy with positive pressure ventilation remains the most reliable and widely used method, especially in infants and patients requiring continuous support. Mask ventilation is less invasive and can be used in cooperative patients, often allowing nighttime-only support. Fanning nerve pacing offers greater independence, but requires intact fanning nerve function and careful patient selection. Negative pressure ventilation is more physiologic, but tends to be less effective and more difficult to use, particularly in the supine position. So each modality has its own advantages and limitations. The key point is that there is no single best option for all patients. Management must be individualized. Now, moving from the choice of modality to how we actually manage ventilation in practice. The cornerstone is positive pressure ventilation, whether delivered via tracheostomy or mask. When setting the ventilator, we need to carefully adjust inspiratory and expiratory pressures, backup respiratory rate, and minimum inspiratory time. The goal is simple: to ensure adequate and consistent ventilation, especially during sleep. When the patient lacks spontaneous respiratory drive, although alternative options such as fanning nerve pacing or nerve pressure, negative pressure ventilation are discussed as potential modalities. In reality, they are not widely available in Korea, largely due to limited accessibility and cost issues. So in our setting, management still relies mainly on positive pressure ventilation. And regardless of the modality, the fundamental principle remains the same. provide reliable ventilatory support tailored to the patient. Okay. This slide summarizes the key principles of respiratory management in the CCHS. First and most importantly, ventilatory support is life support in these patients. So our target must be clearly defined. Oxygen saturation is 95% or more, and a normal range of PCO2 between 35 and 45 millimeter mercury. One critical point to remember is oxygen therapy alone is not sufficient and can be dangerous. It may correct hypoxemia, but it does not address hypoventilation and can actually worsen hypercapnia and lead to acidosis. In terms of ventilator strategy, pressure-controlled ventilation is preferred, especially in the presence of leaks. We set IPAP and EPAP independently to achieve adequate tidal volume and adjust respiratory rate and inspiratory time according to the patient's age. Finally, an important caution, modes that rely on spontaneous breathing, such as CPAP or pressure support modes, should be avoided because these patients lack a reliable central respiratory drive. So overall, the goal is not just oxygenation, but effective ventilation and CO2 control. This slide highlights how clinical practice has evolved over time. Traditionally, tracheostomy with invasive ventilation was considered the standard of care, particularly in young children. However, more recently, there has been a shift toward non-invasive ventilation, even in selected pediatric patients. And in some cases, transition from tracheostomy to mask ventilation is now considered feasible as the child grows and becomes more cooperative. So overall, the trend is moving toward less invasive support. However, this shift is not without consequences. Choosing between invasive and non-invasive ventilation often involves important trade-offs, particularly in growing children. Let me show you a clinical example of this. In this slide, I would like to show a very illustrative case from our practice. These images are from a pair of twins, both diagnosed with CCHS. Importantly, the image on the left show the patient we are currently discussing, who is managed with tracheostomy ventilation. The images on the right show her twin sibling, who is managed with non-invasive mask by PAP. These differences in management led to different outcomes. The sibling on mask ventilation was able to develop speech more naturally since there was no tracheostomy. However, over time, as you can see on the right, she developed mid-face hypoplasia and mandibular underdevelopment, likely due to chronic mask pressure during growth. In contrast, the patient with tracheostomy did not show this degree of facial deformity. So this case clearly illustrates a key clinical dilemma. Non-invasive ventilation improves quality of life in some aspects, but may lead to long-term craniofacial complications. This is why the choice of ventilatory support always involves trade-offs. And this brings us to an important question. Can you find alternative approaches that reduce invasiveness without these complications? Given these trade-offs, the next question is, can you find alternative ventilatory strategies that reduce invasiveness while minimizing long-term complications? This is where alternative modes of ventilation come into play. In particular, two approaches are gaining attention: frame nerve pacing and negative pressure ventilation. These modalities aim to reduce dependence on tracheostomy or mask ventilation, improve patient comfort and mobility, and potentially avoid complications such as craniofacial deformity. However, as I mentioned earlier, their availability remains limited in some settings, including Korea. Still, they represent important directions in the evolution of CCHS management. Let's look at these options in more detail. So these are two main alternative approaches: diaphragmatic pacing, which uses phrenic nerve stimulation, and negative pressure ventilation, which mimics more physiological breathing. Both approaches aim to reduce reliance on conventional positive pressure ventilation. I will briefly go through each of these in the following slides. Let's start with diaphragmatic pacing. Traditionally, this approach has been based on electrical stimulation of the phrenic nerve, which induces contraction of the diaphragm. More recently, alternative approaches have also been introduced, including direct diaphragmatic stimulation, where electrodes are implanted into the diaphragm itself. So in addition to phrenic nerve stimulation, there are now different ways to activate the diaphragm. In both approaches, the goal is the same: to activate the patient's own breathing muscles rather than delivering positive pressure from outside. In that sense, it particularly bypasses the central respiratory control problem in CCHS and can produce a more natural pattern of breathing, particularly during sleep. Now, what are the advantages of diaphragm pacing? First, there is no need for a tracheostomy mask, which significantly reduces invasiveness. It also allows a small and portable system, greater independence even in children, and importantly, the airway remains completely free. So patients can speak more naturally, eat without obstruction, and avoid mask-related complications. Another key benefit is it helps avoiding long-term issues such as midfacial deformity, which we saw in the previous case. So overall, the diaphragm pacing offers a way to reduce invasiveness while maintaining effective ventilation and can significantly improve quality of life in selected patients. However, it still requires surgical implantation and is not universally applicable. So while it is a promising alternative, it is not a complete solution for all patients right now. Let's now look at another approach. Let's now look at negative pressure ventilation. Unlike positive pressure ventilation, which pushes air into the lungs, the approach works by creating negative pressures around the chest. During inspiration, negative pressure is applied to the thorax, leading to chest expansion and allow an airflow into the lungs. During expiration, the negative pressure is released, allowing the chest to recoil and air to flow out. As illustrated in the figure, the external negative pressure expands the chest wall, generating airflow into the lungs in a more physiologic manner. So in contrast to positive pressure ventilation, this method more closely mimics physiologic breathing mechanics. For this reason, it has gained renewed interest as an alternative approach in selected patients. One practical application of negative pressure ventilation is biphasic curious ventilation. This is a non-invasive system that applies negative and positive pressure to the chest using a shell-like device. It has several practical advantages. It avoids tracheostomy, it is relatively easy to use, and requires only a short training period, which can facilitate earlier discharge. In many cases, it can be used during sleep only, allowing patients to remain device-free during the day. Importantly, the face is completely free, so it avoids mask-related complications, including facial deformation. So overall, this approach represents another way to reduce invasiveness while maintaining ventilatory support. However, as with other alternative modalities, its availability is still limited in many settings. And this highlights an important point. While multiple options are emerging, accessibility remains a key barrier in real-world practice. Finally, let's briefly look at future directions. CCHS is fundamentally a genetic disorder, most commonly caused by mutations in the FOX2B gene, leading to impaired central control breathing. So naturally, gene-based therapies strategies are being actively explored. These include gene replacement approaches, allele-specific silencing, and other molecular strategies aimed at restoring normal function. However, it is important to emphasize that all of these approaches remain in the preclinical stage. So at present, they are not yet available for clinical use. That said, they represent a promising direction for the future with the potential to move beyond supportive care toward true disease-modifying therapy. Until then, optimizing ventilator support remains the cornerstone of management. Thank you. Jisoo, please.
Thank you, Dr. Saw, for the review on the treatment modalities. So for our patient right now, normally at 6 years, we would talk to the parents about transitioning to mask ventilation from the tracheostomy. But in this case, because the patient has some developmental delay and she's not that cooperable, it's a hard decision to make to transition to the mask because you need the patient to cooperate to do the mask ventilation. So right now, we haven't decided on transitioning her yet. And I would like to wrap up our today's talk with some take-home messages. So first, we need to think of CCHS in unexplained hypoventilation, especially during sleep. When there is persistent hypercapnia without primary lung, neuromuscular, or cardiac disease, we should suspect CCHS because it can only be diagnosed when there is suspicion by the clinician. To confirm the diagnosis, FOX2B testing can be done. And because it is a systemic autonomic disorder and it's not just a respiratory disease, there are various evaluations that need to be done in terms of GI, cardiology, neural crest tumors in certain mutations, and also neurodevelopmental issues need to be addressed. And ventilatory support is life-saving and lifelong. It cannot be weaned off unless there's other modalities like diaphragm pacing. And it can be sometimes you need to have adequate support during sleep, and in some severe cases, even during wakefulness. And this prevents neurocognitive injury, and it's important to survival. And novel therapeutic approaches are emerging, such as some pharmacologic stimulants or gene-targeted therapies, but it's still a long way to go. And diaphragm pacing and phrenic nerve pacing is available in some countries, but in Korea right now, we don't have phrenic nerve pacing. We do have diaphragm pacing, but it's only approved for adults right now. So we're trying to work on expanding the approval to children also. So I think today's discussion was very fruitful. Thank you everyone for the participation, and I would like to hand it over to Dr. Changgeun Kim. Thank you.
Okay, thank you very much for our presenter and panelists and all guest speakers. Until this late time, the Korean time currently is 11:15, and I guess that the questions maybe by the here in chat room. So I think we don't need to discuss at this time point, and I would like to is Professor Arun there?
Evening, everyone.
Okay.
Yes, I am Professor Arunwan Prichapan from Ramathibodi Hospital, Mahidol University, Bangkok, Thailand, and also the immediate past president of APPS. So before we close today's session, I would like to take a few moments to reflect on the very interesting grand round. Today, we have participants more than 110, which is a good number. So we are very proud that we have Asian population attend our grand round. And today's case was very challenging. And I think that all of the country in Asia have this kind of case. But we can help each other to, such as try to help the other country when genetic test is not available, we can send to Korea or something like this. So today we learn a lot and we have to work more. And I'm very glad that the gene therapy may be a promising treatment in the future, maybe more than 10 years from now on. So I would like to extend our sincere thanks to KPAD, the Korean Academy of Pediatric Allergy and Respiratory Disease, for the strong support and collaboration in organizing this grand round. And I do hope that APPS and KPAD can have a tight relationship and working forward together in the future. And my thanks not only goes to the presenter, moderator, and panelists, but special thanks to Professor Ann Go, the producer behind every monitor today. And looking ahead, I would like to invite you to join our next APPS Grand Round on the last Friday evening of May, which will be hosted by Macau. And in addition, I would like to encourage everyone to submit abstracts and join us the APPS Scientific Congress in Hong Kong from October 30 to November 1st. And the abstract submission deadline is July 15. And we are going to have the award for the best posters too. And before we close, please notice that on the chat box, you will find two links. One is for the evaluation form. So please make comment, feedback on this form so that we can improve our grand round in the future. And the second link is for the certificate. So if you would like to have the certificate, please complete this form in the chat box. And I would like to thank all the questions and the response in the chat box so that we can learn from each other in the chat box. So thank you once again for your participation. And I wish you the restful night and bye-bye and hope you join us again. Bye-bye.
Okay, we hopefully continue this cooperation in our future work. As a Korean, this is our first time to participate, but hopefully continue this kind of work. And thank you. I wish you all success and have a good night.
Thank
Everyone,
you.
bye-bye.
Bye-bye.
Bye.
Bye-bye. And please have a look on our video before closing.
Ladies and gentlemen, I'm Dr. Chiu Wah Keung, the President of the Hong Kong Society of Pediatric Respirology and Allergy. Our warmest welcome and invitation to you all, our dear fans. Join us in Hong Kong for the 11th APPS Annual Scientific Congress in conjunction with the 29th Hong Kong SPRA Annual Scientific Meetings, which will take place at the Cortes Hotel on October 30 to November the 1st, 2026 in Hong Kong. The theme of the Congress is Towards the Best Respiratory Health. This seminar will bring together top-notch speakers from all over the world, whose pioneering research and clinical expertise are shaping the futures of pediatric pulmonology. We are confident that this Congress will be a significant and unforgettable experience featuring a comprehensive scientific programs alongside the enjoyable social program. The seminar showcases the latest technological innovations and treatments in pediatric respiratory care. Don't miss the chance to meet delegates from our regional member society. Looking forward to seeing everyone in Hong Kong. Apart from joining the seminar, you are welcome to explore around the city, where is a fusion of East and West. Modern skyline meets rich traditions. The iconic landmarks, which include the Victoria Peak, which give you panoramic views of the city and the harbor, as well as the Tsim Sha Tsui promenade when you scroll along the waterfront. Hong Kong is also famous for the culinary delight. You must try the dim sum, which are the traditional Chinese cuisine. We have multiple Michelin-starred restaurants and local Dai Pai Dong, which serve various nice food. Moreover, we have delicious seafood feasts in Sai Kung and Aberdeen. For cultural experience, one can visit the Temple Street Night Market, which is a vibrant street food and shoppings. One can also visit Ngong Ping 360 and the Big Buddhas, which provide cable car ride with scenic views. Empress Museum is Asia's leading museum of contemporary visual culture, showcasing groundbreaking art, designs, architecture, and moving images. Hong Kong Sports Park is world-class sport and entertainment venues. You are welcome to go for seeing concerts or watching sport activities. Moreover, there are family-friendly attractions in the city, including the Hong Kong Disneyland, which is a magical theme park for all ages, as well as Ocean Park, which serve marine life, rices, and conservation educations. Looking forward to meeting you all in Hong Kong this year. Thank you.